Welcome, everyone. This is Suzette Benford again from the Alzheimer's Association, and today we're going to go through Module 5, Practical Dementia Case Management, and the DONR. And I'd like to thank Sarah Eckert with the Georgia Division of Aging Services for her very helpful input on this section. Okay. So Alzheimer's and dementia case management has complexities built into it that set it apart from other diseases that might be involved in our cases. So what makes it unique? First of all, the client or the family member may or may not have a diagnosis of Alzheimer's. Lots of people either don't realize that anything is wrong, or even if they do, they might not have received a diagnosis yet. So you might be going into a situation where the dementia hasn't been identified yet. And hopefully going through this section, we'll talk about some things that might be red flags and might be things that make you think that dementia might be affecting the person. And then we also have the effects of dementia caregiving on the caregiver. People who take care of people with dementia are under an extreme amount of stress. And we see very often the health effects of that. Caregivers of people with dementia often sort of give out before the person that they're taking care of. And so we have to be really mindful that these folks may be doing what they're doing very well at the present time, but they might not be able to continue much longer, especially given the present situation. And then we have the need to consider the caregiver and the care receiver's needs when making a care plan. As we've said before in this series, if your client is the caregiver, sometimes the best intervention that you can put into place is something that will benefit the caregiver. And then we might need to think out of the box about the resources that are going to be helpful for this person. We have in our toolkit the usual things. We have housekeeping and respite and home-delivered meals and things like that. But we also might need to think about things that would really benefit, say, a caregiver. For example, they haven't seen the doctor in 3 years, but they're diabetic and they haven't been managing their diabetes. So we may need to really make sure that the caregiver has their own health needs taken care of, and that might really be an intervention that would really help the situation. And then we really need to provide resources for education on challenging behaviors. We need to educate caregivers about the disease in general, but especially I think the challenging behaviors are one thing that many caregivers just have no idea how to deal with, and giving them education and ideas on how to deal with them can really be helpful. So caregivers really play a central role in any case where dementia is present. And again, even if the client is the care receiver, the caregivers are just vital in the situation. So the more they are educated about the disease, the more they're educated about managing challenging behaviors, the more able they are to recognize the care receiver's medical issues and their conditions, the more able they are to minimize their own stress, the more that they're able to feel like they're part of a team in this caregiving situation, then the more that the person with dementia, their medical conditions are going to be able to be managed better in an outpatient setting instead of being admitted to the hospital when things happen. So there will be a decrease in unnecessary hospitalizations and readmissions. And also, it's more likely that we will decrease or delay placement for these folks into facilities. We do want people to stay at home for as long as they possibly can, as long as it's safe and healthy for the caregiver and the care receiver. And then generally, the more this is happening for the caregivers, the better the quality of life will be for both them and the care receiver. So as care managers, as case managers, and people who work at the AAA, we've got several assessment tools in our kit. And the one that we're going to be focusing on today primarily is the DONR. It does a great job of identifying problems with daily functioning, But as we know, the difficulties that your clients have in many areas of functioning are sometimes caused by their dementia. So the problems aren't necessarily physical or in the body, but in the brain. And in this module, we'll give you some input relative to dementia and the DON. So for each area of function, we're going to look at and consider what are some red flags? What are some things to look for that might indicate the presence of dementia? Why might these things be happening? And how can we help the caregivers deal with these issues? What are some potential strategies that might help them? And finally, we'll look at how to use the comments section of the DON most effectively. Okay, so we want to remember that today we're not going to cover all the intricacies of scoring the DON, but we do want to remember that the DON is administered the same for mental and cognitive and physical issues. So the effect of dementia or cognitive impairment on the various level of function should be considered when you're scoring it. An impairment is an impairment regardless of the cause. So if a person has difficulty with a task because of their dementia, that does need to be considered when you're scoring it. So here's an example. Mrs. C is not physically impaired. She has the physical ability to use utensils and eat, but because of her dementia, she needs help staying focused on the task of eating. She has to have someone reminding her to take a bite. Otherwise, she can become distracted and stop eating altogether. So we need to consider her cognitive impairment and how much cueing or prompting she needs when we're scoring the DON. Okay, so initial issues to consider. People with Alzheimer's disease and other dementias who live alone are likely to be more functional than those who live with others. If the person has to have a certain amount of functional ability to be able to be alone, but they are more likely to use social services. So if you see that a person is physically capable of doing their household tasks, for example, but you see that they have been using housekeeping or home-delivered meals, that can be a starting point for identifying those people. Because if they're physically capable of doing those things, why have they needed the services in the past? And then since it's rare that people call you or they say to you, I'm looking for the services because I have dementia. That's unlikely, especially among live-alones. It's helpful for us to try to get information from a third party. And it might be a person who may or may not be familiar with the present situation because we're looking at the person's norm prior to what they are able to do now. So obviously it's helpful to talk to somebody who knows what's going on now, but even a person who knows what the person's previous level of functioning can be helpful. Some possible red flags that you might see during the assessment process are when the person's responses seem very vague, they're not answering your questions specifically, and often, very often, you'll see that they're deferring questions to family members, or they'll just kind of laugh it off and say, oh, I just haven't thought about that in so long, I couldn't tell you. You're asking them specific questions but not really getting answers. Even when you're forming your questions and framing them so it might be a yes, no, or response, the person might have trouble with that. And they have difficulty recalling recent events or circumstances. So this might manifest by that they can't tell you how much or when they've seen the doctor. They can't tell you about their medical appointments, how their health has been, or if you ask them, what have you been doing lately? What kind of activities have you been involved in? They have trouble telling you that too. And a big red flag is often when people are losing interest in activities that they have always really enjoyed. For example, if someone's always gone to church religiously and they're just not interested in doing that anymore. That kind of apathy is one of the warning signs of dementia. And changes in personality and behavior. For example, if a person has, always been a fairly calm and even tempered person and now they're angry and irritable. Or if they're more passive, if they're less responsive, if they're not answering questions, or if they're suspicious. Suspiciousness is often a red flag. Very often people with dementia will believe that people around them, their family members, are stealing from them. Sometimes you'll see spouses who believe that their spouse is having an affair. So that suspiciousness can be a red flag. So we also need to really look in a caregiving situation is whether or not the caregiver is capable of providing safe care. Are they capable of doing it physically? You know, very often we see very frail older women, for example, trying to take care of very large husbands, and they're having to help them physically with a lot of their tasks, and they're sort of destroying their own health in the process. I've seen so many caregivers with who've had to have back surgery and hip replacements, and a lot of that is due to the physical demands of caregiving. And then we need to look at whether the caregiver is capable of providing safe care psychologically and emotionally. Some people are more cut out to be caregivers than others, and some people really, really struggle with it. You know, one extreme example of this is, let's just say that a caregiver is an adult child who's trying to take care of a parent who's been very abusive to them. Psychologically, that has an extra layer of complexity to it, and it makes it even more difficult. And then, is the caregiver able to understand the caregiver's needs? Are they educated enough about the disease to provide care? And are they able to be educated enough to provide care? That's a really, really important component. And then we need to consider, can the caregiver continue to provide care? And is there a backup plan? We have a lot of caregivers who are just hanging on by the skin of their teeth. They're doing it, but their own health may be suffering, and they may really be sort of at the end of the time when it's appropriate for them to be giving care. So we need to look at, is this situation appropriate, and if it so happens that they're not able to continue to provide care, do we have a backup plan? Is there someone else who might be able to step in? Or have we considered what the plan might be for placement? And then we have to think about, does the caregiver have dementia? I'm sure that you've seen in your own experience more and more caregivers who have been stepping up, taking care of their loved one, but now they're having some cognitive impairment as well. So that's another thing that we really have to look at in terms of, is this a safe situation going forward? So when we look at the unmet need of care, and when we do the comments on the DON, we really need to take a close look at these issues. Many times, again, caregivers are doing what they need to at the time to take care of their loved ones, but we need to consider what their limits are and what their abilities are. Or maybe for someone who's living alone and who's getting lots of help from a caregiver, is the level of caregiver involvement enough? Is there anyone else helping? Is there a sufficient support system that makes it safe for that person to still be living alone? Or do they need more help? Okay, so next we're going to go through the ADLs and the IADLs on the DON, and we'll talk about these three areas for each one of those. First of all, we'll look at things to look for. In other words, what might indicate that dementia is present in this situation. Number two, we'll look at potential causes of the difficulty they might be having related to dementia. And then third, we'll look at potential strategies or ways for caregivers to help the person and to deal with the difficulties that they're having. So these lists that we're going to be seeing for each one of these areas are not all inclusive. We don't have time in one PowerPoint to have really exhaustive lists of these things. And if you'd like more information on any of these areas, we can help you with that. And we do have topic sheets that will be available to your AAA that you can look at and also share with your families. But these slides really, they're intended to help you get used to thinking about how dementia might be affecting each area and how we can help caregivers with those. So first of all, we have eating. And the first area, we're going to have things to look for, potential red flags. It might be unexplained weight loss. losing more than 10 pounds without trying, failure to thrive, symptoms of weakness and dizziness, difficulty with chewing or swallowing. Those might indicate that there's some cognitive impairment. So here are some of the potential causes for that. A person with dementia can be very resistant to eating. They may need cueing or reminders to eat. They may be forgetting to eat. The caregiver might be aware of the problem and just not know what to do about. Sometimes caregivers are so overwhelmed by the situation that they just can't do problem solving. They don't know to try different things. Or they could have their own, physical issues, cognitive issues, or mental health issues that get in the way of helping the care receiver to eat. And again, the person may have issues with chewing or swallowing related to their dementia, because as we know, as dementia progresses, there are often issues with both, especially swallowing, in the later stages. So here we have the third part of this eating section, which is potential strategies. And these are things that you can suggest to caregivers to try. Simplifying meal times for people who are later on in the progression of the disease. If you simplify the area and sometimes even give them a little bit less on their plate, it makes them more interested in eating, and it distracts them less to have less things on the table. So for example, if the person is not able to use utensils themselves anymore, you could try finger foods and have a meal of that. So, and favorite meals, things that the person likes to eat and easy to eat foods, and allowing the person time enough to eat. It takes sometimes a long time for people with dementia to finish a meal. And we don't want to rush them. We want to allow them plenty of time to eat. And we have to express to caregivers that sometimes that takes a lot of patience. And sometimes if we cue the person, that helps. If we cue them, if they can still pick up the fork, but they just need to see somebody else doing it before they understand, we can use that modeling. And we talked about modifying the consistency of diet depending on if there are any chewing or swallowing issues. And then, of course, weight matters. If the person has lost more than 5% of their total weight in a month or more than 10% over 6 months, we really need to look at medical attention for them, have them seen by the doctor. And then it's important to have a practical toolkit to share with caregivers, as we mentioned before, like our eating topic sheet. You can actually sit down with the caregiver and go over that with them to find some potential strategies that might work for them and their loved one. Now, just in the interest of time, we have combined some of the items on the DONR. And again, this is just to kind of get you in the habit of looking for the different items, of looking at potential causes and ways to help caregivers. So some things to look for might be changes in personal hygiene, grooming and dressing, and you can't rule out that those things are caused by depression, but depression is very common, especially in the earlier stages of dementia, so that might be a factor. Poor hygiene observed by others. The person might be wearing soiled clothes or clothes that are inappropriate for the season or for the social occasion. At some point, people with dementia can't coordinate their clothes, so they'll wear very mismatched things. Another thing to look for is that they just can't dress and undress without help, even though they have the physical ability to do it. And their hair might be very unkempt, unwashed. Someone who's always been very meticulous about their hair, or for men, someone who's always shaved every day, they might be unshaven. Those are things to look out for. And in this area, potential causes, for someone with Alzheimer's, they may forget how to perform these tasks, or they forget how long it's been since they last bathed or groomed. And this is a big one. The person often feels very overwhelmed by just the tasks involved with these ADLs. There are so many steps, and they get hung up after the first step or two, so it can just be too confusing and too overwhelming. And then when somebody does need some help from someone else, that represents a loss of independence for them. It is a loss of independence and their dignity. They might be a very, very private or modest person, not want other people to see them without clothes, and so they may be just deciding not to ask for help and not to bathe. And like in other areas, they may be depressed and unmotivated to do their personal care. And the caregiver's goals here may not be realistic. We really need to look at that. And potential strategies, first of all, the caregiver needs to understand the person's true capability and have realistic expectations. Having a bath, a tub bath especially, every day is not always necessary or not always practical. People with dementia don't need to have a daily bath in most situations, and caregivers sometimes need permission to sort of let some of those things go. And also, we need to allow as much independence as possible for the person. For example, if you can get them to sit down in a shower chair in the shower and then hand them the washcloth, they might be able to do most of the bathing, most of the work with the washcloth. We need to make sure that the temperature is right, that the situation is safe, that maybe you have a chair, shower chair if needed, handrails if needed, and that the general safety environment is good for that person's level of ability. And then we need to respect the person's personal preferences. For example, if somebody has always taken a shower and they've not been one for a tub bath, then we need to keep doing what they've been doing as much as possible. Here are some other potential strategies. Making bathing as pleasant as possible, a comfortable environment, a calm approach. Sometimes caregivers will even make it like a little spa environment. They'll light a candle or something. Then this is a big one. If you ask a person with dementia if they want to bathe, very many times the answer will be no. So it's all about the approach. So you can say instead, well, come with me and let's just get a wash-up. Or come in here with me and let's just see if we need to use the bathroom and wash our hands. And then after we wash our hands, we can say, since we've washed our hands, why don't we go ahead and wash you up a little bit more? But if the person really still resists, it's better not to push it right then. It's better to look for an opportunity, a good opportunity later, and try again. And again, remember that full-on baths are not necessary. Sometimes a sponge bath, just a little wash-up, can be an acceptable alternative. Or if a person has always enjoyed going to the beauty shop, that's an easy way to take someone, if they're still able to get out, to go to the beauty shop and have the beautician wash their hair. That makes it really easy, and sometimes the person feels like that's a treat. And same with the barbershop for men. So now we'll move on to transferring. Things to look for: impairments in balance and mobility that are increased to the extent that the ability to form ADLs and IADLs are affected. The person might be falling more. The person seems physically capable of transferring, but they have to have assistance to do so. Those are obviously things to look for. And in terms of dementia, the reasons can be that this is just part of the disease process for many people. They may have trouble with motor skills, with visuospatial ability, and those things may play into the difficulty with transferring. Or they can't remember the sequence of transferring. You have to put one leg out, then the other, then sit up, then stand up. And as simple as that seems to us, for somebody who's getting into the later stages, just that simple sequence might be too much. And they might not be able to make good judgments about their ability to walk and their ability to have good balance and to transfer. So we need to look at, sometimes people with dementia, they seem physically like they might be able to do these things, but cognitively they're just not able to. So here are some potential strategies. Helping the caregiver get advice about anything that might make it more helpful for them. But again, if we're going to suggest these things, we have to make sure that the caregiver has the ability to use them properly. For example, I have had a situation where the caregiver had somebody in very late stage, and they had a Hoyer lift in the house, and they just were not able to understand how to use the Hoyer lift properly, and they dropped the person. Another potential strategy for caregivers might be to really look and anticipate needs so that they can provide the assistance when needed instead of waiting and the person needs something and it's not being done for them, so they get up and, for example, go to the bathroom. So trying to anticipate what they're going to need can help. And we find that caregivers really struggle with this. They feel like they're failing on some level if they're not able to provide physical assistance. So we really need to talk to them about how their needs, their physical needs and their emotional needs are as important as the care receivers. And they really shouldn't feel like if they're not able to do this anymore that they've failed. And we can discuss options with them. And you can also, as an alternative, tell them to call us at the Alzheimer's Association, and we can talk about, decisions around when it's time to look at placement or planning for placement. We can help with those things. The next one is continence, and obviously things to look for, bad smells. The person might need assistance with the actual mechanics of toileting. And then for just about everybody with dementia, as people move into the later stages, they will lose control of their bladder and then the bowel. Potential causes, inability to recognize their natural urges. People just don't recognize that they need to go. They might forget where the bathroom is, so they will go in unusual places. And they may be on a lot of medicine, and that can definitely affect people's continence. And the doctor, sometimes if it's really severe, we need to look at medical conditions affecting it as well. So potential strategies for caregivers, making it easier to find the bathroom, label the door, or put a sign on it or a photo on it. Sometimes putting a picture of a toilet can help. Keeping the bathroom door open or painting it at a bright color just to make it stand out. Monitoring medications for their effects on incontinence. Sometimes people don't realize that sleep aids and anti-anxiety meds can relax the bladder. And don't withhold fluids. We have sometimes caregivers who start to withhold fluids very early on in the day because they don't want people to be incontinent at night. And so this can really lead to dehydration and UTIs. Dehydration is just in general a big concern with people with dementia because they don't remember to drink, and sometimes it's hard to get them to drink enough. But what caregivers can do is limit the intake of fluids before bedtime. And some more potential strategies. Consider removing waste baskets, planters, and other things which may resemble a toilet. During the years that I worked in nursing homes, we had lots of folks, especially men, using the waste basket as the toilet. And toileting schedules can be really helpful too. Once every 2 hours, asking the person or taking them to the bathroom, reminding or cueing the person to use the bathroom if they're able to go in by themselves, and then considering incontinence products. One resource is the Alzheimer's store. Your AAA has the information about the Alzheimer's store, and there are other online stores that have all kinds of great products for use with people with Alzheimer's, not just incontinence products, but lots and lots of different things. But if a caregiver can just maybe use pads on the bed, that might alleviate the need to change the sheets so often, and in turn decreases their caregiver burden. So just little things like that can really, really help caregivers. So moving on to managing money. Now we're getting into the IADLs, and obviously because these things are require higher thought processes and they're more complicated and they require more steps, these are the things that people with dementia are going to start to have trouble with earlier. So managing money is first. Things to look for. The person, even if they've always been able to do it, they can't write checks anymore or balance their checkbook. And I'll tell you that this is often one of the first red flags that families see. The loved one might be not paying the bills, paying them more than once, or if they go to pay for something, they can't count money or make change. And they look back at the taxes, and the taxes haven't been filed, the tax records aren't together, and they realize that this has been going on for a while. Also, spending money unwisely and poor judgment related to money, this is a huge issue, and very often people with dementia will go through lots and lots of money before anyone realizes that anything is wrong. And so it's one of the another one of the big red flags that families recognize. People are spending lots of money on things that they don't really need, or they're being scammed out of their money potentially over the phone or in person. So obviously the changes in the brain that affect a person's judgment and ability to manage money are things that are occurring very early on in this process. And very often these changes occur even before there are enough other signs or symptoms for the person to be diagnosed. And so again, we really need to be on the lookout for these things. So strategies. Caregivers need to be educated about the fact that this is a very early red flag so that they can be on the lookout for it. And the person might not have other obvious signs of impairment. And the person often, very often, lacks insight into their loss of abilities. And again, they might lose lots of money if oversight isn't provided. So caregivers need to find a way to monitor finances and involve other trusted people if the person is resistant to their getting involved. And caregivers, this is something that they often really have difficulty with. They're reluctant to intervene because, let's just say, for example, you're an adult daughter and this is your dad, and your dad's always been he's always been the one to take care of the money, and he's very capable of doing that, and he is not interested in anybody being in his business. That's really, really hard for caregivers. It's a sensitive subject, and we really need to be able to talk to caregivers about that. And again, we can help talk to caregivers about that as well at the Alzheimer's Association. And another thing that I've seen a lot of is that in spousal relationships, the other spouse might have never done the finances before, and they just don't know how to take over. They don't know that there's an estimated tax payment that has to be done quarterly, or they may not know where that there are investments here and there, or they may not know that there's some property that needs to have separate property taxes paid on it. Now, just because a person has dementia, though, it doesn't mean that they should be not allowed to do any of the financial tasks. They should be allowed to be involved to the extent that they're able. So, like for example, if you give the person, a checking account with a limited amount of money in it, that can go a long way to make them feel like they still have some independence, and then you can still talk to them about the financial decisions that are being made. But we really need to remember that powers of attorney and other advanced directives also, obviously, but powers of attorney really should be signed while the person is cognitively able to do so. And we need to be careful about who is getting the power of attorney because, we've heard in our financial exploitation trainings that power of attorney for some people is a license to steal. We need to try to do what we can to make sure that the designated POA is someone who's really willing and able to handle the money and to do what's right for the person. And again, the caregiver should know where all the documents are located. Okay, so telephoning. Along with managing money, that requires knowledge of numbers, and telephoning sort of falls into that same category because someone with dementia might not recognize or dial numbers correctly, or have problems with the sequence of numbers. And cell phones are getting more and more complicated. I have to get people in my office sometimes to help me with mine. And so very often people with dementia lose the ability to operate a cell phone. I worked with a man who couldn't figure out how to charge his cell phone, and he was living alone, and his daughter reported to me that he had bought 6 cell phones, new cell phones, before they figured out what was going on. Other things are sometimes if in dementia, word finding is difficult, verbal expression gets more difficult, so they might have difficulty actually talking to someone on the phone because of that, or especially because they can't see the person that they're talking to, they might have difficulty following a conversation on the phone. And causes, the changes in the brain, again, affect the person's ability to recognize numbers, and there's too many steps involved in using a phone. They might lose the capacity to recognize familiar voices, and that's another one of the things that makes them vulnerable to scams, because they don't know who's calling. They think that, well, I feel like I should know who this person is, and so that makes them vulnerable. So strategies, caregivers often really need to be coached on exactly what to do and how much independence to let the person have and how much control they need to exercise. So we need to help them adjust the person's telephone use based on what their abilities are, what their capacity is. Another thing that caregivers can do is consider getting on the no-call list. That can help some with having solicitors call. And if the person is still driving, and many of the people that I work with who are in very early stage are still driving, they should have a phone with them and be able to use it. And if the person is able to be alone, they need to be able to dial 911. Okay, so preparing meals. You'll see very often that people who have always made a recipe just right and made a dish just right, never needed a recipe, can't do that anymore. And as the dementia progresses, they can't do simple things like operate the stove. They might leave the burners on, or they can't even make coffee when they've always been able to make coffee or heat water or make toast, those simple things. Because even for a simple thing in the kitchen, it often requires a lot of steps. And another red flag that you can look for is that the person is losing weight because they can't remember how to prepare meals anymore. And they might forget how to store food properly. Potential causes, again, they forget how to use the things. There's too many steps. They forget that certain food needs to be stored different from other food. And they might not recognize when they're hungry, and they just stop trying to prepare their meals. So strategies, caregivers really just need to monitor the person's weight, and if it becomes an issue, they really need to have a plan to address that. And obviously, oversight of meals and meal preparation are probably going to be needed. So here we've combined housework and laundry, and obviously things to look for are messy, cluttered, unclean living areas. When the person's always been more of a neat person especially, we need to look for changes from baseline. They might have pest infestations. They just don't have the motivation or the initiative to keep up with the household chores. They have trouble organizing objects and items around the home, so you might see something that's in a completely wrong place than where it should be. And on to laundry, they might be able to figure out how to use the washing machine. If coin-operated machines are used, say for people who live in a high-rise, they might not be able to figure out how to use the coins. And because of this, their clothes may be soiled. So, the person with dementia, these tasks can just be overwhelming. They might be forgetting how to do things, and it might just be too overwhelming for them. And not just for the care receiver, but for the caregiver. When you're taking care of someone 24/7, the housekeeping often has to go by the wayside because you're so busy with the tasks of caregiving. The person with dementia may be depressed again, and that's why the house isn't being kept up. And again, the inability to organize items or sequence tasks. And so potential strategies for caregivers, housekeeping assistance can be valuable, not just for the person with dementia, but for caregiver too, because it can be so overwhelming. And decluttering can be very helpful for both the person with dementia and the care partner. I've had lots of folks with dementia say to me, I just felt so overwhelmed in my house until I just went through and got rid of most of my stuff, and when I had just what I needed there, it made it so much easier to go through my day. So it really can make a difference. And obviously we need to address the pet infestation when it's present and have clear walkways. And with the laundry, at some point beyond very early stage, most people are not going to be able to do that, and so alternate plans need to be made for laundry. Outside the home, things to look for in this area are that people are failing to keep appointments, or they're showing up on the wrong day or the wrong time. They can't shop for clothing, groceries, household items without having help. And here's a big one. They may become disoriented or lost, even in familiar neighborhoods, and this might lead to wandering. I've had lots of people tell me that they were on their way to the grocery store, say, somewhere they'd been 1,000 times, and all of a sudden things just didn't look familiar, and they didn't know which way to turn. So this is very common. And so people who have always been able to use public transportation, they start to get off at the wrong stop, or that becomes unsafe. And then what you see with these folks is that their life space starts to decrease because they have trouble going outside. They just start to kind of hole up in the house, live in a little area, and they get more and more isolated because of this. So if you see people who are really isolated, that can be a red flag. And causes, obviously dementia, the damage to the brain is causing the loss of orientation to time and to place, and there are just too many steps involved. So strategies for caregivers. Caregivers often have trouble with balancing the person with dementia, their independence with their safety. And so we really have to do some education with them sometimes about what's safe and what's not, and how much independence a person can have and how much they shouldn't have. And counseling can really help with the real difficult conversations like giving up the keys, and we at the association can help with that too. And in the last module, we talked about safety, and caregivers should really consider the Medical Alert Safe Return program. That can be very, very valuable if people wander and are lost. And this is one of the biggest stressors that caregivers have, and so I think it's important for us to recognize that and to really help them as they go through this journey. And driving assessments are always an option for people when the caregiver isn't sure if they should be driving or not. So some more about driving. We have a really terrific booklet to recommend for you, and a lot of you may have seen At the Crossroads, Conversations About Dementia and Driving. It's put out by AARP and the Hartford, and there's a link to it here. You can order, I think it's up to 20 or 25 at one time, and they're free. And these can be really, really helpful for families and for caregivers. Now, driving assessments can be very helpful, but we also find it really helpful if the care partner or another trusted family member rides with the person and just really observes their ability to drive. And the litmus test is, would you let your children ride with them? Are they safe enough so that you'd let your children ride with them? If they're not, maybe we need to go to next steps. And convey to the caregiver that the physician can be the bad guy if the keys have to be taken away. If the physician is willing, that takes the onus off of the family to be the one to say, I'm taking the keys away, and the physician can potentially be the one to say, given everything I know about you, I don't think you're safe to drive, and I'm going to write you a prescription. Do not drive. And then we should talk to the caregivers about making plans for alternate sources of transportation. What kind of support system do you have around you who can help with transportation? What are some of the options that we have? And if a person refuses to stop driving, we really may need to get to the point where we remove the keys, disable the car, or remove the car. And those are very difficult conversations to have, and unfortunately we talk to caregivers a lot about this because it's one of the most difficult steps that we take. Okay, so routine and special health, things to look for. The person repeatedly and unintentionally fails to take their prescription instructions or perform other health care tasks. They don't appear to understand or remember what they're supposed to do, and they can't learn or retain the ability to perform new tasks. For example, if someone is prescribed a new medicine or if they need to start taking their blood sugar, they just can't learn how to do that. And of course the causes are memory issues, and these things often are things that take a lot of steps, like for example the blood sugar monitoring, and so their sequencing ability affects their ability to perform them correctly. So potential strategies. Very often we hear caregivers say, well, you know, I go in and I set up Mom's pills in her pill minder, and then when I go at the end of the week, they're all gone. And so she's taking her meds right. I'm setting them up for her. But just because the person has a pill minder doesn't mean that they're taking them appropriately. They can be just throwing them away. They could be not taking them or taking too many, or the person might think, you know, for each one of the compartments on a pill minder, that might be for 1 o'clock, 2 o'clock, 3 o'clock. Or, you know, many times I'll hear families say, when I went to clear out Mom's apartment, I found medicine stashed all over the place. So they might put it to the side or, you know, stash it somewhere and think, well, I'll take that later and forget. Or they might not think they need it, so they're hiding it. So the caregiver needs to, you know, really think about monitoring the person and adjust their level of oversight based on the person's ability. And caregivers shouldn't assume that just because the person has always been able to do it, that they still can. Even in the early stages, their ability to take meds is affected with many people. And caregivers also need to be aware that sudden and unusual changes in cognition or behavior can be a sign of an adverse medication reaction or just a medical condition. So the more they're taught to really tune in to those sudden and unusual changes, the more likely it is that they'll be able to, with the doctor's help, identify what's going on and try to fix that or treat it before the person ends up going to the hospital, for example. Okay, being alone. Things to look for. The person has had preventable injuries or safety incidents, like leaving the burners on. We've had lots and lots of folks causing fires in the kitchen, or they've taken too many meds and they've had adverse reactions related to that. They've gotten lost in the past. They've been exploited by others, including family members. Unfortunately, a lot of exploitation is done by family. We need to look for whether or not they could identify or respond appropriately to an emergency. And we have to consider if their level of disorientation or their ability to reason or problem solve would make being alone unsafe. So strategies, we just need to be helping families look at the big picture and determine whether or not it's safe for that person to be alone at all, or if maybe they're safe to be alone for very brief periods of time, or what the big picture is. And we need to help them enlist the support of family members and others if that's available. And obviously, if a person is alone when they shouldn't be, it's unsafe, and there's just no other plan to deal with that, we might need to make an APS referral, or we will need to make a referral. And then assessing for safety is crucial, and we do have a handout which will take you through some safety steps that can be helpful. Okay, so just some assessments, caveats about assessment tools in general. We have to remember that some forms of dementia may not involve memory impairment in the very early stages. The behavior, the judgment may be more effective. So if you're looking just solely for things based on memory, you might miss something. And the client with dementia is often not an accurate source of information. So getting information from others, if you can be really, really critical. And their cognitive abilities may fluctuate, so don't let that throw you. A person with dementia can be really, really pretty functional one day and not so much the next. The memory can be fairly good one day and not so much the next. And or if somebody knows that they're being assessed, they might really get adrenalized and have a really good day and fool you. So we need to consider all of those things when we're doing our assessments. Okay, so a little bit about the Donar comments section. And again, thanks to Sarah Eckert for helping me with this. The comment should be accurate, specific, and thorough enough to really be able to prepare a good and appropriate plan of care. So just saying that the person has dementia in the comment section, that's really not enough. And here are some elements of a good comment. We need to list what essential components of the area of functioning the person can or cannot do, and what the limitation is. And we need to say what the reason for that is. We need to note any kind of assistance or assistive technology they use, what kind of support they receive, and other information that you think might be pertinent to developing a good care plan. So in the example of Mrs. C that we used before, the lady who had difficulty eating, we might say, for example, the client has Alzheimer's and will forget to eat if not prompted. She also needs frequent cueing throughout meals to take a bite, and daughter is present at all meals. Okay, I hope this section has been helpful for you. And in addition to Sarah Eckert, I also want to give many thanks to the Rosalind Carter Institute and Elaine Larkin for their assistance with this webinar series. Thank you very much.